councils, our honorable guests, and our colleagues. We're the Multidisciplinary Team Group. I'm Dr. Tom Chan. I'm a medical oncologist from National Taiwan University Hospital.
I am Dr. Shui Sin Wen, consultant medical oncologist from Yangon General Hospital, Myanmar.
I'm Shinya Tane, a thoracic surgeon in Kobe University Hospital, Japan.
I'm Frederick Ivan Ting, a medical oncologist from the Philippines, and we have with us our coach, Dr. Martin Stockler from Australia.
So today, our group is here to talk about strategies to create a culture of multidisciplinary care when limited specialists are available. So you have listened to all the numbers and charts. We're going to start with 3 true stories of our patients from hospitals with limited specialists. First is a breast cancer patient who just had a mastectomy. A few weeks later, she went to a clinic where you found out after the CT scan, she already had lung metastases. Could this mastectomy be avoided if there was a multidisciplinary team discussion before the start of treatment? Second, a nasopharyngeal cancer patient who had a skull-based invasion despite the best of the medical oncologists that they can do by giving chemotherapy. Radiotherapy was not available because of limited resources. Could this be avoided if there was a multidisciplinary team to have a discussion between the radiation oncologist and the medical oncologist to prioritize who to receive these treatments? Lastly, a patient who has a rapid aggressive disease and you really need a diagnosis before you can give a correct treatment. Whether this is a lymphoma or a urine sarcoma, you have to wait for 2 to 3 weeks before the pathologist can give you a diagnosis. If there was a multidisciplinary team, could we have the diagnosis in a shorter time to really treat our patients earlier? Why are we seeing these patients in hospitals with limited specialists? Because in a hospital with limited specialists, the culture was have to do everything on my own. They think, they trained that they have to finish this on our own because they have no one to depend on. But that is what we're here to change. We want to change the culture. How are we going to change the culture? We want to change the culture to the culture of collaboration. And the culture of collaboration in the treatment of our oncology patient is best demonstrated in the multidisciplinary team approach. And that fits in line with the challenges was given by the ASCO Asia Pacific Council last year to us. What are the strategies to create a culture of multidisciplinary care when limited specialists are available? To have these strategies, we start with one hospital. And we started with Yangon General Hospital, where Dr. Win works. Why we chose Yangon General Hospital, one of the most important reasons is shown here in this figure. As you can see, the blue line depicts the number of oncology patients. So during COVID, you can see the number of patients decreased, but gradually in the past couple of years, it has increased to the number pre-pandemic area. But what is the red line? The red line is about the number of oncologists in Yangon General Hospital. So during COVID, the number decreased, but one of the reasons, because of the coup in Myanmar, you can see the number of oncologists did not come back after the COVID, because a lot of doctors did not come back to their post. So what we're seeing is a highly disproportionately patient and oncologist ratio. And because of this, before COVID, Yangon General Hospital actually does have an MDD ongoing right now because of the stress of every oncology patient and because with the limited specialist culture, the MDD has not resumed. And that is what we're here to do. So our vision is really for the cancer centers in Myanmar to provide world-class management using a patient-centered, multidisciplinary team approach. And to that mission, our To that vision, our mission is to establish a culture of patient-centered, multidisciplinary team care in Yangon General Hospital by maximizing available resources and utilizing efforts as a model for hospitals in Yangon and Myanmar. So, Dr. Win?
We did a survey in Yangon General Hospital. There were 37 out of all 42 medical oncologists, radiation oncologists, and surgeons. The survey includes 22 questions. The questions cover multidisciplinary team logistic features membership. It also includes leadership and team culture. It also includes education, evaluation, decision-making process. We also identified barriers and challenges for effective multidisciplinary team meeting. 30 out of 37 doctors agreed that Yangon General Hospital has limited specialists. Also, 33 out of 37 agrees to re-establish multidisciplinary care team meetings in Yangon General Hospital. So we identified barriers. The most important perceived barriers by respondents to effective multidisciplinary care includes busyness, lack of interest, and unwillingness of others to cooperate, and willingness of others to share decision making. It also includes funding as a barriers. So we need support for effective multidisciplinary care team meeting. We need quality assurance, which means resource-oriented guidelines that are aligned with the evidence-based cancer care. The other important supports are the sufficient staff, technical support, and financial support. Dr. Tanny.
So, strategy to promote a culture of multidisciplinary care is overcome limited time, people, and logistics. First of all, 2 weekly multidisciplinary team meeting could be held with alternating cancer types. In order to maximize efficiency of multidisciplinary team meetings, it could be important to select cases most likely to benefit from multidisciplinary care and to make templates for brief presentation and to encourage input from each discipline for each case. That is, each member could prepare to document and present the current status and the history of patients presented in the multidisciplinary meetings. In addition, it is important to collaborate with the other hospitals. Actually, because resources were limited, it could be necessary to provide specialties such as medical oncologists and surgeons, and also medical facilities, including radiotherapy, to the other hospitals, or to provide the subspecialty training to the other hospitals, all of which could lead for the patients to receive the optimal cancer treatment presented in the MDT. Overcome attitude is encouraged collaborative team dynamics, where the treatment plan should be freely discussed. And good atmosphere, good team dynamics could be hindered by hierarchy, especially in Asia-Pacific regions. So the chairperson could make a good atmosphere so that each specialty give input for each cases. Multidisciplinary care meeting could serve as a forum discussing deliberate multidisciplinary research and also identifying multidisciplinary research questions, which could lead to conduct a potential multidisciplinary research in the future. Dr. Ting.
This is our implementation plan. At this point, we're almost done with phase 1, which involves initial assessment and considerations of the situation in Yangon General Hospital. And with 33 out of 37 physicians handling patients with malignancies in YGH, we would want to proceed to phase 2, which is to implement a structure of multidisciplinary care team meetings to guide the physicians in Yangon General Hospital and ensure that whatever is discussed in these meetings are actually translated to patient care. Once that is in place, phase 3 includes review and refinement of these processes so that we can make sure that the multidisciplinary care team is actually responsive to the changing needs of the stakeholders, most especially our patients. And phase 4 involves expanding the program beyond Yangon. Concretely, our next steps would include reactivating the multidisciplinary care team meeting by October of 2024, and by January of next year, we aim to apply for the ASCO Multidisciplinary Care Workshop, and hopefully, after 6 months from application, by July of next year, Yangon General Hospital will take the lead in running the ASCO Multidisciplinary Care Workshop to involve other hospitals in Yangon and possibly around Myanmar. 6 months after running the workshop, we will be doing the post-implementation evaluation and feedback to note how to improve the program. We all know that treating people with cancer requires a team effort, but a team will only be a team when there is that culture of collaboration, and this is where we step in, and with ASCO's help, we can change this in Yangon General Hospital and in Myanmar. Culture of collaboration that basically binds everyone towards a common goal. And remember the 3 patients presented by my colleague, Dr. Chen? Maybe, just maybe, when multidisciplinary care is established in Yangon General Hospital, in Yangon or in Myanmar, the next time a patient with metastatic breast cancer comes in the clinic, the team could offer chemotherapy first before offering surgery. And maybe, just maybe, the next time we see a patient with nasopharyngeal cancer, after a multidisciplinary care team discussion, chemoradiation can be offered instead of simply giving chemotherapy. And maybe the next time we see a patient, we would be able to get the correct diagnosis at an earlier time after a multidisciplinary care team meeting. Our mission is to establish a culture of multidisciplinary care in Yangon and Myanmar, but we also hope that this can be modeled all throughout the Asia-Pacific region where resources are limited. We are truly thankful to all the people, especially ASCO International and ASCO Asia Pacific, for giving us the opportunity to be trained for the past year, and most especially for guiding us in this project and modeling an efficient MDT. We end a few minutes before schedule. Thank you very much, and we're very happy to receive any questions.
Again, it's a wonderful presentation. Congratulations. And I think the team built up very well. Program has a very focus. But I found out there is no role for hospital administrators. You know, as we know, we all work in the hospital, and everybody's key opinion leaders. So you always talk to the people who disagree with you, which is our culture. But sometimes very important is from hospital administrators. If they support, they against, they consider time wasting from multidisciplinary or encourage that quality factor. So that's really a mindset from administrator. Do you see whether you can convince the Myanmar hospital administrator to buy in this idea, which maybe even help faster and more? Yeah, I just congratulate to you and just bring up this issue.
Thank you for that, Yan. This hospital administrator is one of our stakeholders. We do need to bring them because it is part of the culture as well. So your recommendation definitely fits into our model as well. Maybe we haven't presented it very clearly, but that is definitely also part of the whole system that we need to put the culture into to have this multidisciplinary and collaborate culture. Thank you.
Thank you for, I think this is a brilliant idea because we don't have a routine MDT in Vietnam also, and I really want to learn from your experience in this project. And I think MDT is not only beneficial to patients but also to doctors because it is very educational. So do you think it is helpful to measure like the feedbacks in terms of educational benefit to persuade the administrators and measure how many cases will be managed differently after MDT so that you can resolve the lack of interest and lack of willingness to cooperate? And also, I don't know if it is compulsory in Myanmar to maintain the CME to maintain the license. And I think if we incorporate CME accreditation in the MDT, it will be increasing the willingness. Thank you.
Yes, thank you. It is a great suggestion. Yes, during our survey, we identify we cover the questions of the multidisciplinary team logistic. How many patients we will discuss? Each patient will allow how duration of each patients to be discussed. So I think we will see because we aim to re-establish in October. Then we will get more feedback from the patients and from the administrators also.
I wanted to ask a few different things. The first is, did you look at, in Yangon, are there any specialties that you don't have? And did you work out where you might go to get that person who you don't have, radiation, surgery, whatever it is, to attend the MDT? Is that a practical possibility? That's my first question.
Yes, sure, yes.
So you've identified and you know you'll be able to get these extra people to add the knowledge. The second issue is you don't know what you don't know. So if you have, you said that one of your criteria is, they've got to be complex cases or cases that would benefit. Every one of your 3 cases would not get to your MDT because the person looking after them would say, I already know what to do, the chemotherapy case, because they didn't do the appropriate chest X-ray, right? The second case, maybe they don't know anything about the role of radiation. And the third case, you're waiting 2 weeks for a pathology result to come back. No MDT is going to make that shorter by even a day. It's what happens internally in the anatomical pathology department and the quality assurance to say they have the knowledge to distinguish between those 2 cases. So it's kind of the thinking about who to present. Just saying it'll be complex multidisciplinary cases will be a problem for the kind of solution you want. On the other hand, you only have a certain amount of time and you can't look at every case. So maybe I'll have one more question.
Thank you. I think the way we're thinking this is by steps. So we're putting in our steps. The complex is, of course, the first step, but we have feedback. And the feedback is, if these complex cases, we're raising awareness of the multidisciplinary team approach. We're still missing these cases that we have mentioned, like the first 3 cases, and then we need to change the rules again just to fit that we're going to give the best treatment to our patients.
And my third question is about, as I asked before, what are the ideal outcome measures, hard measures beyond satisfaction, that if you had the opportunity to do that, what questions would you ask?
Yeah, that's a very good question, Dr. David. We've thought about this very hard. What are the outcome measures? So going back to our objective, which is to change the culture, not reintroduce the MDT, but to change the culture. Our primary outcome would probably be the level of engagement of the different specialties in managing patients with malignancies. That would be the primary outcome. There are so many secondary outcomes. Some I'll mention some. Survival would be one. Compliance to standard of care would be another one. And of course, the feedback from the stakeholders themselves, including from administrators down to the patients and their families, would be definitely considered. Thank you.
I have 2 questions and a comment. The first question, in terms of the multidisciplinary approach that I think it's key, do you discuss or thought that maybe even prior to that, there could be a process of standard guideline implementation, right? That there are certain patterns that for a patient with breast cancer, locally advanced matted lymphadenopathy has a CT scan, right? Like certain steps that then at the time of multidisciplinary meeting, that information it's available, right? Because if you wait 2 weeks to then discuss that patient needs a CT scan and then you schedule it, by that time, it's been too long. So that's one. And the second question, it's about culture, right? You emphasize how important that is. Did you discuss, in addition to your program, aspects related to education of the new generations? When I think we're going to see that, if the new trainees, young doctors bring this as a way to practice oncology, the future might be better.
Yeah, I'll answer the first one. As mentioned by Dr. Tanya earlier, part of the plan is to create templates for patients with cancers being seen at Yangon General Hospital, and for the multidisciplinary care team to identify patients who would go through that pathway. One of the things that were discussed was patients whose cases are not clearly covered by the clinical practice guidelines that we currently have, whether international and local for the Asia Pacific. So that's one. And of course, number 2 would be the quote-unquote rare tumors that is specific for Yangon General Hospital.
Yes. For the education one, there are 2 types of the multidisciplinary care team. One is we aim for the prospective. We will select the cases and then we will present and we will find out solution or best decision making for the cases. For the educational, we will do the retrospective and then we will teach the younger generations about the multidisciplinary team care outcomes, and then we can do retrospectively.
And the comment that I wanted to make, it's more reflective of what we've been hearing. So all of you got tasked with very challenging situations that are real and that are not isolated. They all are present in the same countries, right? You have issues with primary care doctors that are challenging making the diagnosis, treatments that get delayed, and then doctors that spend too little time with the patient. So in the same place, you have the 3 problems. So I want to congratulate you all and invite you as leaders in your countries to think about all these issues as a process, right? We have problems with resources and processes that we all need to optimize. So it's just, a thought about how all of this we're thinking about it as 3 different problems, but it's really part of all the challenges that we're experiencing taking care of patients with cancer.
Thank you.
And, you know, I'm intrigued, and this isn't so much to you for as much as it is to ASCO staff and the LDP program and all. You've outlined a fantastic strategy that had 4 or 5 steps that you would plan to do over the next year, year and a half. But your LDP project, isn't it completing now? So what is it? How are we going to help that? And it's applicable to the other 2 projects as well. There are pieces that you've proposed that are not finished yet. How are we going to help you finish those so that you can actually test what you've done? And I also, as a side note, think since Yangon is one of the City Cancer Challenge cities, is there a way that this specific project could be tied to something within the CCAN project? Yeah.
No, just to build on Julie's point, and it's something that Vanessa and I talk about and we've discussed in the council. So there are various sort of streams for following up on these projects. First, I want to again congratulate each of the teams because I think what you have produced, I'm being repetitive what you've already heard, but just to highlight it, you've taken very complex multifactorial challenges and you've produced very concrete, practical solutions in each of these 3 things. So that is hugely impactful, and it's just been fascinating to listen to and to think about. Some of the actions that you propose, you've already identified some ASCO opportunities that you in turn can apply for. So I think that is point number 1. You've mentioned the MCMC course, applying for an MCMC course. Others have highlighted the collaboration in Sarawak and the great work that's being done there, so forth. For some of these tools, there are additional opportunities to apply for. So where you have a pilot program and you have the results, we've already heard about the poster presentation, submit that to JCO Global Oncology, get that more out into the community. For those areas that are not natural fits with ASCO opportunities, I would challenge the regional council. This is where the regional council earns your salary. Of course, you don't have a salary, but this is where you earn your keep, is to look at these proposals. This is the raw material, not really raw, but these are the insights for this council to take a look at and say, what should ASCO be picking up here and taking forward? That's not a staff question. That's a regional council question for you to digest, not only for these specific projects, but what are some broader themes that you can incorporate into your discussions about what ASCO should be doing globally. So those are some of the opportunities. The last thing we want, Julie and everyone around the table, is for these to be interesting conversations that go nowhere, right? So these are insights, practical ideas that can either go to standard ASCO opportunities. If there are not standard opportunities, let's have a regional council discussion about what are the other things that there's a role for ASCO. And to be honest, some of the things ASCO will not have a role, right? And we need to be sort of aware of that and be disciplined about that, but have a conversation around that.
Can I make a comment about that? This group charged Vanessa and the team with building a leadership development program. Can you see that these 12 oncologists have gone from what's leadership, what's leadership, to very effectively thinking about this on a very personal level, extraordinary presentation skills, ready to be front line at all your meetings, thinking about projects and strategic planning, which is very much a part of what we've done, and thinking through. They've gone out and they've interviewed a lot of different people, yet maybe they didn't till the soil completely, as you've suggested, but of course, isn't that your next challenge, is challenging them to the next steps? We could do so much within a year, but giving you back very concrete ideas of what next steps could be, as you just described it. I want to really thank the council for saying this is something really important. Because as clinicians, and this was true for me on a very personal level as well, I didn't get leadership training as a physician. I got clinical skills training. I didn't even get really good speaker training until I really embraced this. Can you see that in a year, the program that you've crafted with the help of Vanessa, this is Mother over here, looking after everybody on a very specific level. Yes. Yes. And the team at the Center for Global Impact empowering this with you, with membership services, and these 3 fabulous coaches. You have taken these 12 folks a step, just as you've took the first cohort a step. Can you be proud yourselves for thinking about this? And how does ASCO embrace this on an ongoing basis? Because there aren't just 12 oncologists in this region who need this, are there? How many oncologists in the region need this? To really move this forward and embrace the change you're hoping for? I want to say on a very, very personal level, and maybe I can speak for Shannon, I want to thank you for this opportunity. It's extraordinary. And you've given all of us the fertile ground to grow. Namaste to all of you, and namaste to all 12 and the coaches. Thank you.
So not to have the last word, but that was beautifully articulated. As I was listening to the comments that are very constructive, and very helpful, what I've observed in talking with the LDPs yesterday and today in past groups is exactly what you articulated, is the development of leadership skills, because that's not what you're taught, along your medical training. It's the clinical skills. And what I've seen is a very decisive, well thought out way to define the problem, understand where you want to go, and can you possibly develop solutions to get there. My expectation is you're not going to have all the answers. And it's a trial and error, nor is the expectation that that would be that. But if we can help as an organization to continue this thought process or your project forward, I'll leave that to the staff, because that's outside of my pay grade. But I do want to encourage you and say that I'm very proud of you personally, and as an organization, we are proud of this group, we're proud of the council, we're proud of the coaches, and thank you so much for being here to move forward our next generation of leaders.
Because I think you're going to finish 4-ish. Yes. Is that right? That anyone who will join us, we would welcome you as we're waiting to give the certificate.